Hello, my name is Dr. Melissa Carter. I'm a clinical geneticist at the Children's Hospital of Eastern Ontario, which is in Ottawa, Canada. I'm going to share my screen here so you can see my slides. Okay, so I'm going to talk to you today about Rett syndrome. And why am I talking about Rett syndrome? Well, some of the young girls and women who have been diagnosed with HNRNPH2 mutations in the last few years had already had a diagnosis of Rett syndrome. So I'm going to explain how that happens and how we can tell the difference and what the differences are, how they're similar, and there's also a lot we don't know yet. So that's my outline. So in case you're not familiar with Rett syndrome, this is a genetic condition, and it's usually caused by a mutation in the MECP2 gene, which is on the X chromosome. And most of the Rett syndrome patients that I have are females. And it is one of the most common genetic conditions causing severe developmental disability in females. And we've known about Rett syndrome for a long time, since I think about the 1960s, and the first doctor who described some girls who had Rett syndrome was obviously named Dr. Rett, Andreas Rett. And so there have been hundreds, if not thousands, of girls identified with Rett syndrome since those early days. So HNRNPH2, on the other hand, like MECP2, is a gene on the X chromosome. And having a mutation in this gene, we now know causes a neurodevelopmental disability syndrome, which is in some ways very similar to Rett syndrome. And it's been called Bain-type intellectual disability, named after Dr. Bain, who first made the connection. And of course, we've only known about this gene for a few years, so the number of people who have been diagnosed with this is still pretty small. So we don't really know how common or how rare it is yet compared to Rett syndrome. But we know that some girls with Rett syndrome who were more recently diagnosed with HNRNPH2 had Rett syndrome as their diagnosis prior to the genetic testing, which showed what they really had. So before I talk about how that happens, I'll just tell you a little bit about what Rett syndrome is for those of you who don't know. There are sort of classical types, and there's variations on that, sometimes called atypical Rett syndrome. But the sort of classic story is the baby girl seems normal for the first several months after she's born, maybe even years. And then a regression occurs. And regression can happen between 6 months and 4 years on average. And it usually affects the child's ability to communicate verbally and to use her hands, and can affect her gross motor skills as well. It also affects her behavior in that she begins to do behaviors that are a little unusual and repetitive. Things like hand wringing, which is a midline sort of rubbing or squeezing of the hands, or other hand movements that are repetitive. She can start breathing in a way that may or may not be obvious to the parents, but if you're looking for it, you see that she's breathing quickly or taking deep breaths and holding them and then forcing the air out, that kind of thing. Grinding teeth, which a lot of us do in our sleep, but girls with Rett syndrome tend to do it while they're awake mostly. And things like waking in the night, screaming or laughing without any sort of reason behind it. Girls with Rett syndrome may or may not learn to walk on their own. Some do, some don't. And they may actually, once the regression period is over, start to gain back some of the skills that they lost. But they may not ever regain the skills that they once had. Some do, some don't. And a lot of other medical problems that I don't have time to talk about today are also associated. So Rett syndrome has been diagnosed in different ways over time. Before 1999, it was based on clinical criteria. In other words, the doctor would recognize the specific pattern in a young girl and would say, okay, she has Rett syndrome, or she meets the criteria for Rett syndrome. We didn't have a gene before 1999. once the gene was discovered in 1999, we were then able to confirm our suspicions of Rett syndrome by doing a genetic test looking at just the MECP2 gene. So today, diagnosis is usually a combination of a clinical diagnosis and a genetic diagnosis. And that can be either when a doctor suspects Rett syndrome and specifically tests for the MECP2 gene, or we've had lots of girls diagnosed with Rett syndrome because they've had another type of genetic test, such as whole exome sequencing, that has shown that she has a mutation in MECP2, much like many of you got the diagnosis for HNRNPH2. I have a couple of examples just really quickly of two patients, one of whom is a former patient of mine, one is not, but I've communicated with the mother of people who have HNRNPH2, but were originally told that they had Rett syndrome. So the first one is a 17-year-old girl who was diagnosed with Rett syndrome when she was 3, and then when she was 15, diagnosed with HNRNPH2. She had a regression at 6 months old, and her mom says she lost her baby spark, which I thought was a really good explanation for what she saw. Over time, she developed a lot of features that look like Rett syndrome: hyperventilation, grinding teeth, difficulty with eating and gaining weight. Her feet would turn blue and purple, which often is seen in Rett syndrome. She had a small head. She never really learned to walk independently. She has a lot of stereotypies, which are those repetitive behaviors. Poor sleep, low muscle tone, which later in her life changed to higher muscle tone, which we often see with Rett syndrome. And the second patient is the now 27-year-old woman who was diagnosed with an atypical form of Rett syndrome when she was 4, and had she did not have a genetic diagnosis of HNRNPH2 until she was 23. She didn't have any regression, so that's quite atypical for Rett syndrome, but it does happen. And her Rett-like features were the late walking, unsteady gait, hyperventilation and breath holding, grinding teeth, hands and feet turning blue and purple, those repetitive stereotypies, hand biting, mouthing, and finger flicking and twisting, and low muscle tone. Now, most of you know that HNRNPH2 has to be diagnosed with a genetic test because we don't have any clinical criteria for diagnosing it. And this is usually by exome sequencing or some related technology. And of course, this technology has only been available for approximately 5 years on a wide scale. So that's why we didn't really know about it until more recently. So how often are girls with HNRNPH2 misdiagnosed with Rett syndrome? We don't know. It hasn't been studied yet. I would guess a lot based on what I so far know about how girls with this present, that Rett syndrome being a very common genetic diagnosis, and we know that not everyone with Rett syndrome has an identifiable MECP2 mutation, that this would be sort of the default diagnosis, which would be very reasonable in most cases. So what do Rett syndrome and HNRNPH2 have in common? Well, they both cause a moderate to severe developmental disability in most cases. There are exceptions, and it's mostly in females, which has to do with the fact that they're both on the X chromosome. Both have abnormal muscle tone, and typically with Rett syndrome, it starts with low tone or hypotonia, which evolves over time into hypertonia, things like spasticity and dystonia, as the girl gets older and into womanhood. And this has been reported in some girls with HNRNPH2, but not all. Both of them affect motor skills to different degrees, so there's a lot of variability in what a girl with HNRNPH2 can do, same with Rett syndrome. And we don't really see a lot of birth defects. It's not a common part of this type of genetic syndrome, although it is a common part of many genetic syndromes. How are they different? Again, we're not really sure yet, but I find that in Rett syndrome, regression is part of the clinical criteria for diagnosis, so it's very common, and we're not sure how common yet it is in HNRNPH2. It does happen for sure. We've seen that, but how common is it? We don't know. Regression could happen later or not at all. Feeding and gastrointestinal problems seem to be very common in both, and that's Not very surprising in a way, because a lot of neurogenetic conditions also affect feeding and the gastrointestinal tract. So I'm not sure that that's very specific to those two conditions. If you do a brain MRI, you take a picture of the brain in a girl with Rett syndrome, it's almost always normal. And the girls who have been so far reported with HNRNPH2 who have had MRIs of their heads, some of them are abnormal, although not very obviously so, but have some subtle differences in how the brain looks. And it's reported that girls with HNRNPH2 may have these so-called dysmorphic features, which is not a great word, but basically some features in their face particularly that makes them look somewhat like each other even though they're not related. That is not the case with Rett syndrome. There are a lot of unanswered questions about this condition. Like I said, we don't know how common regression is. We also don't know what it looks like. Does it look the same in terms of the pattern and timing as in Rett syndrome? We don't know how common seizures and movement disorders are. They are very common in Rett syndrome. They've been reported in HNRNPH2, but we don't have enough data yet. We don't know a whole lot about the stereotypies or these repetitive hand movements. Do they look the same in Rett syndrome? Do they look different? Do girls with HNRNPH2 have better fine motor skills than girls with Rett syndrome? I find that girls with Rett syndrome, even if they can get around really well, their hand use isn't quite as good. And can girls with HNRNPH2 use eye gaze technology to communicate? A lot of girls with Rett syndrome, especially ones that start really early on, who cannot speak but can use their eyes to communicate, have successfully learned to manipulate a computer technology with their eyes that can let them speak and spell. And we don't know yet if this is a possibility for girls with HNRNPH2. So thank you for your attention. I will be around to answer a few questions. And if your daughter was diagnosed with Rett syndrome and you want to tell me more about her, or maybe take part in a small case series, you can email me at mcarter@chio.on.ca. Thanks very much.